Since the original series of 6 operative demonstration videos, we've been increasingly using the N.T.A flap to lengthen soft palates in the management of patients with VPI. And I've been asked by a number of people if I would produce a video of that operation. So this is it. It's the entire operation, as we've shown in the past, although you can safely stop at the end of the sewing in of or repairing of the buccal defects if you wish. We're going to show before the operation a brief extract of this little girl speaking, then followed by a brief extract of a lateral video fluoroscopy, which was actually done in another country. It's not of good quality. It's actually taken off a television screen, but I think you'll get the idea of what the velum looks like. There'll then be the operation, and at the end we'll show the preoperative speech sample and lateral video fluoroscopy, followed by the postoperative outcomes 4 months after surgery. The patient is a 6-year-old girl. She had a cleft palate repaired at the age of about 15 months. She had a fistula repaired in another country at the age of 2 years, another fistula, attempted fistula closure at the age of 3 years, and here she is at the age of 6.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Say ah.
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 Okay. Ah.
Ah.
Pa pa pa, ta ta ta, ta ta ta, ka, ka, prosh, patata, ahwa, تدريش Topake puya dra. Topaka puya dra. Tato kaka shapo pata. Okay, come.
So I think, as you can see from that recording, the levator knee is not particularly well pronounced, but is towards the front of the soft palate, and the lift is not great. The movement is not great. There is a significant gap, probably less than a centimetre. So this is a patient who needs not just a lengthening but also a retropositioning, and in her case also closure of that fistula. So we're going to combine all 3 procedures. So the first step is to make the midline incision, mark the incision at the back of the hard palate from behind the alveolus, and we will also, I've previously marked the commissures because that's it's quite difficult sometimes to spot the commissures. I'm now marking the parotid duct opposite the second premolar and making the incision just below. Some people cannulate the parotid duct, but I don't actually think it's necessary. And the anterior end of the buccinator flap comes to almost to the commissure. The widest point of the flap should be in the middle. That's where you need the maximum length. And it's important not to compromise on the width of the flap at that point. we often use the buccinator flap in patients who've already had retropositioning of the palate muscles, and in some ways I think that's easier and perhaps more reliable, in other words, to do a two-stage repair. But in this particular girl who came from overseas, it wasn't feasible to do that, or at least it was not advisable to do that, so we're going to do all three of these procedures at the same time. A stay stitch, retraction stitch in the commissure is very helpful. This is just a nylon commissure suture. Then you can put a little traction on. So when combining the buccinator flap lengthening with the re-repair, the best way of doing this, I've done it in various ways, but the best way of doing it is to do the re-repair part of the procedure first. However, making the transverse incision in the soft palate actually makes that access easier. So there's our, I'm extending now that flap inferiorly at approximately its midpoint, because I'm planning to use that flap as the oral flap, and if you imagine then rotating that through 90 degrees, in fact more than 90 degrees, that inferior extension will actually go into the fistula defect, or the defect created after excision of the margins of the fistula. So a stay stitch in the other commissure, the right side. The fact that her movement is not very good is a negative feature, but it's always unpredictable. Even after re-repairs, it's somewhat unpredictable to know how much improvement is going to be achieved by retropositioning the palate muscles. So again, marking the flap on the right side. There's the parotid duct. And I find that if with a bit of ink, bit of Bonnie's blue applied to it like that, it tends to remain discolored, to remain blue, which means that it's easy to avoid it. But important to avoid it, obviously, if you want to avoid a swelling of the parotid afterwards. Quite an indurated fistula. So we'll just make an incision around the edges of the fistula and extend forwards. You see that her uvula is a little asymmetrical. I don't quite know where the right side of the uvula is, and the right posterior border of the soft palate on the right side is a little anterior, a little shorter on the right side than the left. So now injecting some local anesthetic. This is 0.5% lignocaine, xylocaine, lidocaine, with 1 in 200,000 adrenaline, and making sure that there's a reasonable amount of local anesthetic injected around the musculature which we're wanting to be dissecting. Actually, with the needle, you can make sure you can feel where the back of the hard palate is, which is helpful. I think this particular local anesthetic mix, it's possible to use, the dose is about 1 mil per kilogram. and injecting the hard pallet around the fistula. And in particular there at the back of the hard palate, lifting up the mucous glands which are attached to the back of the hard palate and to the tensor tendon. And there again is the left-sided flap. You can actually see the pulsation of the facial artery. Sometimes you can almost see the outline of the facial artery. But we're not going to raise the facial artery. So the buccinator flap is based on the buccinator branch of the facial artery, which you don't see, or which I've never seen doing this operation. I don't think you need to go looking for it. It's a myomucosal axial flap, but it does not include the facial artery. It could include the facial artery, but it appears not to be necessary. So just injecting some local into the flap. So we have moved towards doing more buccinator flaps over the last 10 years or so. From our original protocol for management of VPI was to do a re-repair of the palate if there was evidence that the levator muscles were anterior, and then, if necessary, carry out further surgery, usually in about 10% of cases. And that secondary operation used to be usually a modified Heinz pharyngoplasty, or what I call a posterior pharyngeal augmentation palatoplasty. This is quite different from the sphincter pharyngoplasty. This is putting a bulge very high on the posterior pharyngeal wall. However, that's a more major procedure, or quite a major procedure, with a significant complication rate. The incidence of airway obstruction and sleep apnea appears to be very small in that procedure, but there is some obstruction, and it's an operation with a potential complication rate, and it's an unpleasant operation for the patient. So we have tended to move towards doing, or at least considering doing, a buccinator flap as a secondary procedure instead of a modified Heinz pharyngoplasty. As I have said, in this particular case, we're combining the two. We're doing the re-repair and the buccinator flap. But more often, the buccinator flap is used as a secondary procedure. The decision-making about whether to do the modified Heinz pharyngoplasty or the buccinator flap is quite a complicated one, and I don't think we've really clearly worked out the indications. But some of the factors that we consider are, firstly, this is probably a less obstructive procedure. So if there's a risk of airway obstruction, we would probably use this procedure instead of a modified Heinz. If the defect is more than 1 centimetre, then we would normally do a Heinz, because in the paper that we've published in the Cleft Palate Journal, 2013, The first author of that paper was Greet Hens, H-E-N-S. The mean lengthening from the buccinator flap was 7.5 millimeters, less than you might imagine. So if the defect is more than a centimeter, then usually we would we'd do the modified Hines. So here we are making incisions around the fistula and in the midline of the palate. I try not to use forceps to hold tissue in the lip or the palate because it's more traumatic, so skin hooks is much more gentle. The first buccinator flap that I did was, I think, in 2004, and it was for a patient who'd had a VPI following removal of a palate tumour. So this flap can be very useful for cancer reconstruction also. So here we're using the angled beaver blade to cut down onto the back of the hard palate. This is the 69 beaver blade, angled blade. Using here the left hand to cut on the right side. Very difficult to make these angled cuts when you're working from the head of the patient if you are not able to use your both hands. And as in primary surgery and in secondary surgery, it's very helpful to get down to the bony hard palate, elevate the bony hard palate subperiosteally to expose the back of the hard palate. Now I'm going to make the oral incision, the oral transverse incision, just behind the back of the hard palate. And this particular maneuver does make the muscle dissection that much easier because you can get very good exposure of the oral surface of the muscle. It doesn't matter how densely scarred the palate is for this procedure, and that's an advantage of it. So people often ask me, what about the really scarred, battle-worn palate? And I think actually this the buccinator flap is a good operation in that situation. Although, of course, the re-repair part of it may be more difficult. Well, the re-repair we're doing here might be more difficult, but simply lengthening, it doesn't matter how scarred the palate is. So now elevating the oral mucosa of the soft palate in a plane just between the mucous glands and the muscle, and that muscle is the palatopharyngeus, it's not the levator. The levator is not inserted into the back of the hard palate, it's the palatopharyngeus that is. So just trying to keep in that plane between the mucous glands, the oral mucous glands, and the palatopharyngeus. As in the other operative demonstrations in this series, this is an unedited demonstration. It's obviously there are bits of it looking at it again that I feel I could have done better, but it's a warts and all video, as people seem to have found it helpful just to see the whole of a procedure. Actually, her palatopharyngeus muscle doesn't appear to be particularly anteriorly orientated, as we're looking at it there. So we're getting out towards the pterygoid hamulus. And that action of using the knife to both cut and push, very helpful in palate surgery in general. I virtually never use scissors. I will use scissors to dissect the buccinator flap, but I virtually never use it in the palate itself. And I also prefer, in general, to use a gauze swab rather than a sucker. A quick dab with a gauze swab gives you a much quicker view of the structures that you're operating on than doing it with a sucker. And I think a sucker tends to encourage bleeding as well. I do worry sometimes about leaving cotton fragments behind after palate surgery or after any operation. In some countries, cotton gauze fragments very easily, and it's very easy to leave bits behind, which I think is a bad idea. And it's always worthwhile irrigating at the end of a procedure if that's a risk. So here we are again going through dividing the oral mucosa from the back of the hard palate, and then lifting that flap. On this side, I think the levator does appear more anteriorly orientated. Again, using the left hand, the non-dominant hand for doing this dissection. Difficult to do it with the right hand. The non-dominant hand, in my case, of course, different for a left-handed surgeon. I also try to minimize the use of bipolar diathermy, because that each time you use it you create a little patch of necrosis. I work on the basis that this bleeding usually stops by itself, and when you're operating on a palate you can move from side to side. So if one side's bleeding a bit, just go and do a little on the other side. Obviously there are times when you have to use the bipolar, but I try to minimize it. But here we're using it because there's one little arterial bleeder there. Bleeding from the cut edges of the palate are very difficult to stop by bipolar coagulation, and much better for those for that bleeding just to stop by itself. So the other arguments in favour of a buccinator flap over a modified Heinz are looking on lateral video fluoroscopy, and we'd always have a lateral video fluoroscopy if at all possible before doing this procedure, and an endoscopy also if possible, is the vector of pull of the levator. Sometimes when you look at a lateral video, it appears that the levator is pulling almost vertically up, and in that situation moving the levator insertion back by doing a buccinator flap may actually may not improve the situation, so we would tend to use a Heinz in that situation. if there are adenoids present, a significant amount of adenoids, then the buccinator flap, the Hines is really very difficult to do, and we'd usually do a prior adenoidectomy, but that doesn't apply for buccinator flap lengthening. I think the main thing about the buccinator flap is that it is a safer operation. I think I've had a couple of cases of reactionary bleeds after a buccinator flap. That's not a particularly worrying site of bleeding. A bit of pressure will probably control it, and if not, it's easy to access. Whereas bleeding, post-operative bleeding, reactionary bleeding, or a secondary bleed after a modified Hines pharyngoplasty is really can be very difficult. So we've now elevated the oral flaps off the muscle. Now just lifting a little bit, lifting the hard palate just a little, the oral mucoperiosteum at the back of the hard palate. So just to complete that discussion, I don't feel, I'm very reluctant to do any sort of pharyngoplasty in a poor country where patients may return to a rural setting some distance from the hospital. If a secondary hemorrhage or complication may be very serious in that situation. I think, although this is not a trivial operation, I think this is of less risk. So just exposing, getting down in that subperiosteal plane. So this operation's been carried out under the operating microscope, as I try to do in all palatal procedure, if at all possible. Just elevating the oral mucoperiosteum and using the modified mouth gag which we've produced, particularly for use in the using the operating microscope. Most of this is being done at low magnification, probably about 4 times, but you have the option of zooming up for any difficult bits, and it's a much more comfortable position for the surgeon. There's no leaning forward. It's much kinder on the neck of the surgeon. Obviously, in this elevation, being very careful not to go as far laterally as to damage the greater palatine neurovascular bundle. This is a little bit oozy. It may have been better to wait a bit longer after the injection. One of our colleagues in the UK did a little study and reckoned that you had to wait 9 minutes after the injection of local anesthetic and adrenaline. Again, the angled beaver blade, 60-degree angle blade. This particular blade is no longer produced, I think, by the Beaver company, but there are alternatives, and they do a different kind of angled blade, which is not as strong, not as rigid, and I think a little more difficult to use. Using that angled dental scaler to elevate the, looking at a variety of angled dental scalers to get into the right position to elevate the oral mucoperiosteum on the right. Most of the preparation for these cases is the same as for any other palate procedure. We've put in a throat pack, obviously using an orotracheal tube, and this is actually a ray tube, and the patient being ventilated. This dissection is obviously made a little bit more difficult by the scarring, by the rigidity of the tissues, basically. And for that reason, closing the fistula primarily would be difficult. Of course, if we were just doing the fistula, you could make lateral releasing incisions to release the tension, to relieve the tension, reduce the tension. That would be an option. You can see there's still a bit of bleeding particularly on the left side. Now, just putting a couple of stitches in the uvula. Separating the mucous glands a little further back. Generally, in palate surgery, I try and leave most of the mucous glands posteriorly on the nasal side, whereas anteriorly, it's important to get in a plane between the mucous glands, the oral mucous glands, and the muscle. Just opening up the uvula a bit. It's a fairly scarred uvula, or distorted uvula. So using some monocryl sutures to, first of all, close the nasal side of the uvula. In the paper which we published, first author Griet Hens in Cleft Palate Journal 2013, 32 patients were reviewed, and the results were good. As in all secondary velopharyngeal surgery, not all patients were completely cured of their VPI, but they were very encouraging results. But as I said, although the flaps that we raise are usually at least a centimetre and often wider in when they're raised, the mean lengthening was actually only 7.5 millimetres. So everything contracts a bit, and in fact, when you look at these patients post-operatively, the flap tends to bunch up to some extent, and you can actually feel the defect in the deeper structures, which is less than the width of the flap. We used to use a bite block. There's always the worry of the patient biting off the pedicle of the flap, and so they would be given our orthodontic colleagues would construct a bite block for them to make it impossible for them to bite the pedicle at the back. More recently, I have stopped doing that because I take care to anchor the flap behind the alveolus, and that seems to haven't had any problems with patients biting the pedicle since I've been doing that. So it's just one less problem to have to worry about before the procedure. So this is now going to be like any other palate re-repair, except that we have these oral flaps that have been divided from the back of the hard palate, so it actually gives good exposure. And this is just a retraction stitch in the corner of that flap just to expose it. So that's certainly better exposure of the muscles than you get if you're simply doing it from the midline. Although it's perfectly possible, not really a big problem to do it just from the midline if you're simply doing a re-repair. Just cutting off that corner of the nasal mucosa at the fistula site, so that it's we can achieve a reasonable closure of the nasal layer of the fistula, and then we'll be using the buccal flap, the inferior extension of the left buccal flap, to close the fistula, to close the oral layer of the fistula. This is a 5/0 vicryl suture on a compound curved needle. Very useful needle for doing palate surgery. This is actually made by Ethicon as a special suture. Both 4/0 and 5/0 are made, and that compound curved needle is good for getting into difficult places, although I'm obviously not finding it terribly easy in this case. It would be possible, of course, to raise extensions of both flaps, so both the oral and the nasal flap. If the nasal flap, the extension, the triangular extension, would need to go in the other direction. But in this case, the nasal layer could be closed fairly well, so really not necessary. But putting in the extension of the oral flap means that the suture lines are not superimposed. Obviously, the limiting factor in making a vertical extension of the flap is the parotid duct. So, if you're raising a superior extension or a cranial extension, then it has to be in front of the parotid duct. So just a couple of sutures in the nasal there. Trying to pick up the submucosal tissue and thin bites, small bites of the nasal mucosa itself, to get good eversion of the nasal layer. trying to tie good surgical knots, although not terribly accurately here. At any stage, if the bleeding's a nuisance, you can use some topical adrenaline. We actually use 1 in 1,000 adrenaline. I'm not sure I'd want to use it too many times during a procedure, but a small neurosurgical patty or small swab just put on the bleeding spots, bleeding sites, can work very well. 1 in 1,000, especially if it's just general ooze. Obviously, a significant little arterial bleeder, then you'll need to coagulate. Just trying to stop that persistent bleeder. The microscope we're using here is the Vario, the Zeiss Vario. I should point out I'm not getting any financial benefit from mentioning names, but just to make it easier for you. That's certainly a very nice microscope for palate surgery, but much cheaper and simpler microscopes can be used. Right, now with a fresh blade, making an incision, and this is exactly the same as we do with a re-repair, making an incision on each side of the midline, perhaps 4 or 5 millimeters from the midline on each side, and going vertically down. The aim is to leave the mucus glands in the midline of the palate. And you need to go vertically down. You don't want to, otherwise you can dissect out into the middle of the levator. So vertically down until you reach the nasal mucosa. More anteriorly, those incisions come closer to the midline. If we were not doing if we're not going to subsequently divide the back of the nasal mucosa from the back of the hard palate, then I would go right to the midline anteriorly and release the midline scar, but we'll be doing that with the buccinator flap. So just inserting a neurosurgical patty which has been moistened with 1 in 1,000 adrenaline, just to reduce that bit of bleeding from that corner, to make it easier to see what we're doing to the soft palate musculature. So straight incising straight down to the nasal mucosa. We're just beginning to see it there, or getting very close to it. And coming towards the midline anteriorly. And those mucus glands that we're leaving behind will hopefully produce a convexity on the nasal side of the palate, which is important to minimize the chances of a central defect, velopharyngeal defect. There's the nasal mucosa. And now we're getting in a plane between the muscle and the nasal mucosa. And you notice on the nasal layer a plexus of blood vessels. a submucosal plexus, and if you're in that plane, that's the correct plane. And usually the dissection then between the muscle and the nasal mucosa is relatively easy with a knife, only with a knife, and hopefully also the blood supply of the nasal mucosa is preserved. And there again is the nasal mucosa. You can just see, just near the swab, a bluish colour, which is the very typical appearance of the nasal mucosa. I've only in recent years found that it's easier and I think safer and more anatomical to dissect, to find that plane between the muscle and the nasal mucosa before detaching the muscle from its anterior insertion, the muscles from their anterior insertions. You can then be more certain that you're detaching all the muscle. You're not leaving levator muscle behind in the back of the hard palate. I think I've made a bit of a hole in the nasal mucosa there, but it's not. That's not a problem. And in fact, in this operation, as in all palate operations, I will intentionally make a hole in the nasal layer laterally if I haven't done it accidentally before, so that the risk of a fistula, of a hematoma, is reduced, and the risk of a fistula is well, there isn't a risk of fistula if the nasal incision, the nasal hole, is lateral. Again, a little bit of 1%, or 1 in 1,000 adrenaline. You can use more dilute adrenaline solutions, but topical 1 in 1,000 seems to be safe, doesn't seem to have any significant effect on pulse rate, blood pressure. Of course, you need to be absolutely meticulous to make sure that there's no way that it can be injected by mistake. You usually wait 3 minutes after putting these swabs on. And it's useful before the muscle dissection. This is the bit of the procedure that you need to see well, and the bleeding is a nuisance. There are things we haven't studied about these buccinator flap patients. We haven't looked specifically at the effect on airways, nasal airway, by doing pre- and post-operative polysomnographs. That's something that should be done in the future. We ought to see whether, in fact, there is any problem with airway obstruction. We also haven't really studied whether there's any effect on mouth opening, any post-operative trismus. Certainly we haven't had that described by patients or parents, but we haven't measured it. So there's that plane between the nasal mucosa, and you can see the hole that I've made in the nasal mucosa there. So I'll just try not to make that hole any bigger. The hole's fine, but I want to try to make sure it doesn't compromise the muscle dissection. So just trying to get into the correct plane. I think the arguments for carrying out the re-repair and muscle dissection separately are, firstly, that you have a better idea of what you've achieved. In other words, the lateral video fluoroscopy will before and after will show you how much improvement you've achieved. Secondly, of course, it may even then be unnecessary to do the buccinator flap. But I would only do this single stage procedure if I was pretty sure that the palate was going to be too short, as I believe in this case, even with retropositioning of the palate muscles. The other argument for carrying out the re-repair as a separate preliminary procedure is that obviously it's a smaller procedure and you don't have this T intersection, which potentially is an area where healing could be a problem. In other words, you've already made the longitudinal incision, anteroposterior incision, as in the preliminary palate re-repair, and then just the transverse incision at the time of the buccinator flap. However, I think in certain situations combining the two does make sense. And as I've said, the advantage is that it does actually make the exposure of the muscle the oral layer of the muscle very easy. So doing this dissection. So we're now dividing the muscle, and this is actually the plata pharyngeus from the back of the hard palate till we get down to the nasal mucosa. And more laterally, that is the nasal component of the tensor tendon, the tensor palati. The nasal mucosa is much deeper than you expect in many cases. And there's the tensor tendon, just being divided, part of it being divided from the back of the hard palate there. So the levator is inserted anteriorly, but not into the back of the hard palate. It's the palatopharyngeus that's inserted into the back of the hard palate. So now going back to the dissection between the oral and nasal mucosa on the other side, on the left, so the patient's left side of the screen, and now beginning to divide the muscle from the back of the hard palate on the left. I said earlier that I try not to use forceps. There are situations where it's difficult not to use forceps, but if so, I try to take a small bite of the more, well, not the anatomically important, functionally important parts of the palate. In other words, picking up maybe the tensor tendon or some anterior scar tissue in this case. Now dividing the midline scar tissue, and now dividing the nasal layer all the way across. I have tried doing that transverse incision before doing any muscle dissection, but it's easier to do some of that muscle dissection while the nasal layer of the palate is still adherent to the soft palate is still adherent to the back of still attached to the back of the hard palate. It's easier to do the muscle dissection when there's a little tension, and as soon as you release that nasal mucosa, the tension is lessened. So that incision through the nasal mucosa is just behind the back of the hard palate. I'm just elevating the oral flaps a little further to separate them, to make it easier when we close up. So just behind the back of the hard palate. If you can leave 2 or 3 millimeters of nasal mucosa, if you go that's helpful for suturing later. And that release of the nasal mucosa extends right out to the medial pterygoid plate, basically, and you need to make sure that you've freed it up completely. Again, a little bit of adrenaline on a swab. So, it's quite a good idea to now leave that to settle down and the bleeding to stop, and raise the flap. Removing the retraction stitch. Of course, very important to have a swab count if you're using these small swabs. Very easy. It would be very easy to leave swabs behind. I would say that this is a more oozy patient than average, but when you set out to try and do a demonstration procedure, then that's often the case. The other measure that we use more and more, is to use tranexamic acid in a dose of 10 milligrams per kilo IV. Isocapron, or it's got various other names, but very useful antifibrinolytic agent. It does seem to make a difference to oozing and hemostasis. Now you can see the cheek. We just remark that. You can see that mark in the parotid duct there, the blue mark which persists, and then we're going to make that inferior extension, which will turn into the fistula side. The timing, or the sequence of the procedures will change from case to case. If that hadn't been so oozy, I might have completed the suturing of the final dissection of the muscle and the suturing of the muscle before dividing from the back of the hard palate and before raising the flap, but it seemed to be a good idea in this case to allow that bleeding to settle a bit before completing the palate dissection. It would be quite possible to dissect the flaps without using the microscope, but I find it easier to use the microscope for the whole procedure, and obviously for demonstration purposes that's very helpful. We've just lost our stay stitch, so that needs replacing. And the incision goes through the mucosa and through the buccinator muscle. You can see the buccinator lies just deep to the mucosa. obviously getting a little tension on the cheek is helpful. You see we're, what, 2 or 3 millimeters below the parotid duct, and make sure we don't go closer to the duct more posteriorly. And I'm using my left hand there to put a little tension on or a little pressure on the cheek so that I'm cutting against my finger. And as you can see, we're very close anteriorly to the commissure. Now the vertical V-shaped extension, inferior extension. Which of course we wouldn't need to do if we were not, if there wasn't a fistula also to close. And the flap can be narrower posteriorly. In fact, it can be raised as an island flap. It's not essential to have a mucosal bridge, but I've always preserved a bridge just for safety. But certainly the flap can be narrower posteriorly. I haven't seen any damage to the parotid duct. Sometimes there's some cheek swelling, but it's not parotid swelling. I also haven't seen any visible damage to the facial nerve. Obviously, some nerve branches to this strip of buccinator muscle are damaged, but there doesn't appear to be a functional deficit. Now I'm getting down through the buccinator flap, through the buccinator muscle, into a plane. I'm going to say deep to the buccinator. Of course, I actually mean external to the buccinator. And that's a nice and relatively bloodless plane in most cases. So the incision through the mucosa, the parallel incision, should go through the buccinator as much as possible. Now there's the plane between fat and buccinator, and this is where I am using the scissors to open up the plane and to see what we're doing. Often you'll expose the facial artery, or the facial artery will be very close to the dissection. So a combination of knife dissection and scissor dissection, but keeping close to the buccinator. There's the buccinator muscle. You can see as the scissors open, and stay close to it. And then you shouldn't damage any other branches of the facial nerve or any other structures. And below the parotid duct, making sure that that incision doesn't go any higher. There's you see the buccinator muscle becoming exposed. And the aim is to have the strip of buccinator the same width as the mucosal strip. Further back, we'll expose the buccal pad of fat in most cases. There are some little neurovascular structures that you see and have to be divided. The principal as always, is to divide as little as you have to. And obviously avoid the buccinator branch of the facial artery. That's the vessel supplying the buccinator. There's the fat pad, the buccal fat pad. So this flap will be rotated anti-clockwise. And you can then imagine that the inferior extension will then be orientated forwards and hopefully will reconstruct the oral defect at the site of the fistula. Again, using forceps a bit more than I would normally like to do, but trying to do it fairly gently and just confining it to the very front of the flap. Freeing the buccinator off the buccal fat pad. Many surgeons use the buccal fat pad, particularly for fistula closure. It's not something that I personally have experience of, but many feel that it's a very useful technique. Generally, that you have to be more radical about freeing inferiorly than superiorly, because that will be the area that is most likely to restrict your rotation. Now we're going to have a look and see if that flap moves into position. So we'll take out the various little adrenaline-soaked patties, epinephrine-soaked patties, and have a look at the defect we've created and see if that flap has been mobilized sufficiently. So there's the superior extension that I'm demonstrating there. So it does need a little bit more freeing inferiorly. Looks pink. You can see that the mucosal base is really quite small there, and this is the danger area for the buccinator branch of the facial. So as little freeing as you can get away with, but obviously you don't want it to be too tight. I've only seen one, in the patients that I've personally operated on, I've only seen one patient with some flap necrosis, and one patient developing, and the same patient developing a fistula, but it was a complicated situation where the patient was found to have sickle cell disease and had a sickle cell crisis and various complications. But otherwise, I haven't seen any significant necrosis of these flaps. The flaps need to be long enough to reach well across the midline, to reach across to the opposite side, to the alveolus of the opposite side, so that they need to be long enough and free enough to be able to do that. So there's the divided nasal mucosa. Now we're going to raise the flap on the other side. In this case, simply a simple flap without an extension. You can see that just at the bottom of the screen, the blue mark that stayed in the parotid duct. And that's the limit of the superior incision. And then again, wider in the middle, wider where you want it in the middle of the velum. It may have been more sensible to inject the cheeks later in the procedure, as it's been some time since the adrenaline was injected, and therefore the effect has probably worn off to some extent. Again, using a bit of pressure on the cheek from outside to make it easy to cut down through the levator. Through the buccinator, sorry, and completing the incision all the way around to the incision we've made at the back of the hard palate. And so here's the wide central part of the dissection. It's really worth being careful about this. It's easy to make it too narrow. So, it's about 15 millimeters wide at its widest point. And you see the buccinator fibers orientated in an anterior-posterior direction, and those are divided at the same level as the mucosal incision. Very anteriorly, I would not raise the buccinator muscle just at the very front. I don't want to disturb the anatomy of the modiolus. Now we're through the buccinator to a fat layer, which is between the buccinator and the more superficial palate muscles, and within that fat layer is the facial artery. That's the buccinator, and now we'll go through it to get into that plane deep to the muscle, deep to the buccinator, as from where we're dissecting, but actually, of course, superficial to it in terms of the cheek. And now you can see that plane opening up, the subcutaneous fat, or the submuscular fat, the intermuscular fat, and the undersurface of the buccinator muscle. going straight through the buccinator. Combination of knife and scissors. Little curved tenotomy scissors, nice for doing this. There you can just, as it opens up, you can see that you're just deep to the buccinator, just between the buccinator and the intermuscular fat. That's where there's a danger of damaging the parotid duct. And as I said, on the other side, it's inferiorly that you normally need to mobilize more radically. There's the buccal fat pad is just poking out. And that's where the freeing needs to be most radical, but with great care not to damage hopefully not to see or damage the buccinator branch of the facial artery. So this will be the flap used for the nasal layer. So it'll rotate, well, also anti-clockwise actually, to be inserted into the nasal layer. And just a stitch just to hold it back in place while we do the rest of the muscle dissection. So back to the midline, clear the blood out with, and a swab does that effectively. There's our left-sided buccinator flap, which I think needs to be just kept out of the way. So that's the tip of the buccinator flap, and you can see the inferior extension. To some extent, simply dividing the nasal mucosa from the back of the hard palate reorientates the muscle, and this is I guess, related to a general discussion about whether you need to separate the muscle from the nasal and oral layer, or whether, as in a furlough palatoplasty, you can carry out adequate retropositioning simply by leaving the muscle attached on one side, in that case to the oral layer, and on the other side to the nasal layer. Okay, just carrying out that. You can see the adenoid tissue there. Just dividing the nasal layer a little further back, so you can see that palate's almost lying on the adenoid tissue. Now a little more dissection between the muscle and the nasal layer. I feel that the levator muscle particularly needs to be divided from the nasal mucosa. But perhaps less radically in this operation, where we are dividing the nasal layer itself. Bleeding point there. So that nasal defect must be a little more than a centimetre, I would imagine. Just freeing that muscle a little more, and we should be able to actually expose the levator. So down on the nasal mucosa. And then splitting platopharyngeus fibers. And underneath the platopharyngeus you will see the levator, although it's bleeding at the moment. Another little bit of coagulation. Just separating the levator. You can now see the levator on the that's the levator muscle now. You can see the levator very closely adherent to the nasal mucosa. So the palatopharyngeus and the levator come together in the midline, but then diverge. The levator going nasally or cranially, and the palatopharyngeus, or the descending part of the palatopharyngeus, going inferiorly in the posterior pillar of the fauces. A little bit more topical adrenaline. Another look at the muscle on the left side. You can see the left buccinator flap there folding into the mouth. Obviously very important not to, or to get in the right plane and not to damage the neurovascular supply of the levator, but that appears to be fairly immune to damage in that it arises very close to the origin of the levator near the skull base. That's just, that scalar is going down just in front of the levator, now splitting platopharyngeus fibers, and just underneath you can see the levator. This would have been easier before the nasal mucosa was divided from the back of the hard palate, which we left at that point because of the bleeding and waiting for it to stop. But it would have been easier to do that before that step, when the nasal mucosa is fairly tight. We're now operating at a high magnification, as you can see, probably 6 times, something like that, perhaps more. You can see a lot of adenoid tissue there. Right, just a little bit more dissection between levator and nasal mucosa on the right side. And on the left. You're getting glimpses of the levator there. So, if possible, do all the muscle dissection before you divide the nasal mucosa from the back of the hard palate. Now some nylon sutures in the muscle. This is 4O nylon. I use non-absorbable sutures for muscle routinely. You can actually see the levator there very clearly, and that's now just at the front end of the levator. That round muscle. I want to put a couple of sutures that very definitely go through the levator. I'm holding that scar tissue which is attached really to the platopharyngeus. A little more dissection between the levator and the nasal mucosa, but it would have been better to have done that before. So now the 4O nylon suture, this one going through the back of the posterior muscle stitch, usually about 4 sutures in the muscle, 1 orientating posterior stitch, and then at least 2 actually through the levator, taking good bites of the levator. But they also do pick up the palatopharyngeus. My argument for doing that is that that's normal anatomy. As I said, the palatopharyngeus and the levator do come together in the midline, although they diverge laterally. The role of the palatopharyngeus in palatal function is really unclear. Whether it's a synergist or an antagonist, whether it's irrelevant to palate function, we really don't know. Perhaps it's important in the vector of pull. A little bit more freeing of the between the levator and the nasal mucosa on the right side. I hope that this operation will help to avoid pharyngoplasties or reduce the need for pharyngoplasties, and in particular for midline pharyngeal flaps, which I think personally I use very sparingly. I think they create an artificial obstruction. They're not nearly as dynamic as they're supposed to be, and often are often too low and often tether the palate down, restrict palate movement. So that stitch is tied on the nasal side of the muscle. Again, you can see the adenoid tissue in the defect there. So this patient would really have been inappropriate for a Heinz pharyngoplasty without carrying out a prior adenoidectomy, because insetting flaps high on the posterior pharyngeal wall into that adenoid tissue is very difficult. So we would normally, if we were going to do a Heinz pharyngoplasty, we'd do a prior adenoidectomy 3 months before, warn the parents, the patient, that there would be a risk of that the speech will almost certainly get worse, but that it will be hopefully improved after the operation. Now this is the second stitch, which in this case is going through the levator, and again the knot's being tied superiorly. Generous bites. And I always cut these stitches myself to make sure that they're cut short, or at least I can only blame myself if they're not, to reduce the chances of these sutures extruding, in this case on the nasal layer. But that hasn't been a problem in the past. Now a second stitch through the levator. Now you can see the levator clearly there. So that stitch is taking a fairly generous bite of the levator. On the left side. And on the right. When I watch myself in these videos, I realize that I do things that you're not supposed to do, like holding needles with my fingers. So I should say that you shouldn't do that. And you see that's sort of pushing the muscle up a little bit towards the nasal side. So this part of the operation is just the same in a primary palate repair or in a palate re-repair. Now the last stitch is picking up perhaps some tensor tendon and certainly the palatopharyngeus, and there is a bit of tensor tendon attached to it, just to give a little bit more strength to the muscle repair. At least 3 throws just to ensure that that stitch doesn't come apart. So there's the muscle united, the defect in the nasal mucosa, the adenoid tissue deeply, just a little bit more freeing of the palatopharyngeus, just making sure we're fully free. The swab just going down onto the adenoids. Okay, so firstly we're going to sew in the nasal flap, and this is the more difficult one because it's you have to, and the most difficult bit about it is to put some stitches in the nasal layer of the palate anteriorly, just behind the back of the hard palate. That flap looks as though it's going to reach satisfactorily. Now again, this is actually 4/0 monocryl on the compound curved needle. Going through the nasal mucosa, and then that flap rotating anti-clockwise, and this will go in roughly into the middle of or halfway along the flap, close to the midline. And it's very helpful to put a few of these stitches in before tying them, otherwise you can't really see what you're doing. So we put a clip on that, an artery forceps, mosquito, whatever you call them. Just need to make sure that it's not too tight, but it looks fine. A little bit more freeing from the buccal fat pad there. When you're using a microscope for palate surgery, it's nice to have a microscope that's easy to shift, and that's where clutch operated microscopes such as the my Vario are very helpful. And you need to be able to change the position of the microscope easily, and rotate rotate it both from side to side, and rotate the eyepiece from front to back. So a second suture through the nasal layer of in front of the defect, nasal layer of the palate in front of the defect. So the sutures will be external, will be outside the mucosa. And inserting them in such a way that the tension is taken off the tip. In other words, angling those sutures. And the other great advantage of the operating microscope is that the assistant can see through a sidearm. You can take a recording such as we're doing here. And as I said, much more comfortable for the surgeon. Okay, so that looks as though it's going to sit down fairly well. Again, a mosquito just to hold it in position. Very important that both flaps reach well across to the other side, and that what you don't want is the flaps just coming to the midline where you'll get the least benefit. Now a stitch through the left lateral end of the nasal defect to attach the tip of the flap. That's somewhere very close to the medial pterygoid plate. But of course, being careful not to pick up the muscle or damage the neuromuscular supply of the levator. Of course, techniques evolve. This recording is being done in December 2014, about 10 years after I first started using the buccinator flap. And of course, there have been various modifications, and I'm sure there'll be more in the future. And as I've said, some differences with each case. Here I've not done all of the muscle dissection before separating the nasal mucosa from the back of the hard palate. That's not optimal. So we've now partially sewn in the anterior edge of the nasal flap and the tip. Another stitch in the anterior edge of the flap on the right side. I don't believe this needs to be a watertight closure, and I'm sure it never is a watertight closure. It just needs to be secure in position. A more difficult stitch to put in. Now tying that one. And there are various combinations of sequences here. Sometimes I would put some stay stitches or some preliminary stitches through the posterior end of the flap into the posterior end of the defect. In this case, we're going to tie the anterior sutures before doing the posterior ones. And you can see the left flap there sewn, held in position with a nylon suture. There's always a slight problem showing videos of procedures under the microscope because the surgeon has a bigger field of view, so it looks there as though I'm operating right at the limit of the field of view. Actually, it's not like that through the microscope. So just tying the other anterior suture we've put in. You can see how it's easier not to have tied those at the beginning. That would have made getting the last stitch we put in, putting that in position would have been very much more difficult. So far 3 sutures along the anterior end of the flap, plus a suture at the tip. Now the posterior edge of the flap. Again, angling or placing the stitches in such a way that the tension is taken off the tip of the flap and knots on the mucosal surface. So roughly in the midline. So another holding stitch, mosquito on it, just so that we can have good visualization of for the remainder of the sutures. You can see the buccinator flap, the buccinator muscle on the back of the flap, or on the deep surface of the flap. Another suture more laterally on the right side. Trying not to lock the sutures so they run well. And again, this is 4.0 monocryl. Although we've completed the incision from the palate onto the cheek, as you can see, the mucosal surface of the flap is now into that defect, and there will be a fistula there. There'll be a hole through between the pedicle of the flap and the mucosa just at the front of at the back of the alveolus. Now an anterior, a stitch through the posterior edge of the flap to the left of the midline. So just 3 sutures along the posterior edge, 3 along the anterior edge, and 1 at the tip. And you can see the vascularity of that flap looks fine. It's nice and pink. The muscle's pink. Tying the midline suture. I'd like to say they were all proper surgical knots without, you do have to cross over your hands to make sure that each throws in a different direction, but I'm not sure that was particularly accurately done. So that's the nasal flap sewn into position. You can see the buccal fat pad on the right there. Now we can sew up the oral flaps that we've raised for the re-repair. Of course, this step wouldn't be necessary if this was simply a buccenator flap lengthening. So a stitch through the, picking up the nasal layer in front of the muscle, as we do in a re-repair actually, or in a primary repair, trying to close off the dead space there. And then through the left side of the left oral flap. And this is this T junction, which is potentially a risk as far as fistula is concerned, but I don't, to my knowledge, I haven't had that problem after combining a re-repair with the buccenator flap. It's not an aesthetically very pleasing operation. I don't particularly like doing this to a palate. It certainly would be, a straight re-repair would always be my first option, if at all possible, if it looked as though it had a reasonable chance of achieving competence. So a few more sutures in the oral, the anteroposterior oral mucosa, or to achieve oral mucosal closure in an anteroposterior direction. Those oral flaps seem to be well vascularized, those triangular oral flaps. Bleeding seems to have at last settled. This is now using a 5/8 curved needle with 4-0 monochrome. Again, a suture which Ethicon produce as a special suture. It's a useful needle for picking up deep as well as superficial tissue. Here I'm using it just to pass through the muscle as well as the oral mucosa, and here performing a loop mattress stitch. So this is a vertical mattress stitch, and a loop which is twisted, in this case twisted anti-clockwise, twisted clockwise, and the needle is put in through from 12 o'clock. If you put it in the wrong direction, the twist will undo. And the reason, the argument for the loop mattress stitch is that it halves the tension in the suture, and for the twisted loop mattress stitch is that it avoids a little patch of necrosis which can occur. If you don't twist the loop, you get a little circle of tissue enclosed within the loop which can become necrotic, whereas if you twist it, that circle is much smaller. Very useful stitch, not only for palate surgery but for many procedures. Another oral layer suture. Need to be aware of how long a procedure has been going on. As we've done this combined procedure, I think it's taken about an hour up till now, and that's okay, but I would always limit the time for the mouth gag, to maximum of 2 hours. We've had some examples of where procedures have taken longer, where there's been significant tongue edema. So always let the gag down if the for a short period anyway, if the procedure is taking longer than 2 hours. Or at least if the gag is open for longer than 2 hours. Here, as you can see, the tongue is rather squashed to the left. So these are just some simple sutures in the oral layer. As you can see, the oral defect's quite substantial, isn't it? Quite wide. Well, quite considerable in an anterior-posterior direction. Of course, it's the full width of the palate. I use monocryl because it's monofilament. It's relatively non-reactive. Its disadvantage is that it doesn't knot very well. I previously used CatCut, but that's no longer available in many countries, such as the UK. So now we're going to release the left flap, which will become the oral flap, rotated in a anti-clockwise direction, and there's the extension which is going to go up into the fistula. And this is the easier one to sew in place. So letting the gag down for a short time. Decision-making about secondary velar pharyngeal surgery should always be done jointly by speech therapists, speech and language therapists, speech pathologists, whatever they're called in your country. And of course, many of these patients need speech therapy if they have articulation problems post-operatively. We don't believe that speech therapy actually changes velopharyngeal function, but certainly many of these patients have acquired cleft-type speech characteristics, compensatory errors, which will need correction. And many of these patients parents need to be warned. Now I'm going to cut off the corners of this oral mucosa because it doesn't look very well vascularized, and we have this new mucosa to put into it. And many of them parents need to be warned that this operation may not itself improve intelligibility if there are major articulation errors, but that therapy will be required. Just making sure that the nasal layer is okay. So there's that extension we made, the inferior extension in the cheek now becomes the part of the extension of the flap which extends into that fistula defect. repositioning that stitch through the tip of the flap, or through the tip of the extension of the flap, not the tip of the flap. So clipping that, just positioning it before tying it. Now this is the tip of the flap, which goes over to the other side. There are raw areas after this procedure. The pedicle of the nasal flap, or the right-sided flap, will be exposed. That doesn't matter. It epithelializes very quickly. And as I said earlier, it's important to pin this up behind the alveolus to reduce the chances of biting off the pedicle. Well, biting off the tip in this case. On the other side, biting off the pedicle. So again, just a stay stitch or a positioning stitch to make sure that the flap's lying in the right position. Obviously the operation does not take nearly as long if you're simply doing the buccinator flap, if you're not doing the re-repair and the fistula closures at the same time. In fact, it's not really an anatomical operation in that case. It's simply just a straight incision through, separating the soft palate from the hard palate, and then raising the buccinator flaps and sewing them in position. So considerably simpler procedure. If you wanted to fast forward, obviously the rest of this is fairly straightforward. It's simply a matter of sewing the flaps in position, trying to avoid tension on the flap at any point, and making sure that it's well sutured in, but with not too many sutures, and being careful not to take such big bites of the flap that the vascularity of the flap might be compromised. So that looks fine. We can now tie the anterior of those sutures, the one that's holding the extension of the flap into the fistula site. Wherever possible, we would carry out repeat investigations, and particularly lateral video fluoroscopy, because that's the investigation that gives you an idea of palate length and function in a way that endoscopy doesn't. About usually 6 months after the procedure. Obviously this video could be edited to shorten it considerably just to show the key bits, but I think people who've seen the DVDs, the other DVDs in the past, have found it useful to see the whole thing, see the bits that are difficult, the bits where I make a mistake or do it less well than I would like, and that's all part of the operation. So that the suture through the distal end, the tip of the flap. Wasn't happy with that position, so I'm just going to reposition it. Fairly small bite of mucosa of the flap. This is the compound curve needle again. Obviously being a little bit more careful in the suturing at the fistula site to try and ensure that it doesn't recur. It's always more difficult to use a needle holder with your non-dominant hand. For some reason it's much more difficult to keep control of the direction of the needle. Although it's not so difficult to use a knife with the non-dominant hand. Try doing it the other way around. This is the sort of thing that the bit of the procedure would be nice to just edit out not show making such a meal out of a very simple little stitch. So that triangular extension looks viable. So having spent that time putting that in position, it's actually pulled out of the palette anyway. Keep cool and put it back in again. I would say try to if you have to put a stitch back in again, then try and put it in a better position, make it more effective than the first time. Now we're not quite at the tip there. You can see the buckle fat pad on the right. And this is the tip. Or the anterior edge of the flap close to the tip, and again trying to make sure that that's well up behind the alveolus so it's not likely to be damaged by biting. Post-operatively, we usually recommend a soft diet for 2 weeks. Generally, I would prefer to carry out a second procedure anytime after 2 weeks. Most commonly 3 weeks after the operation, just to excise the pedicles. It's not essential, but if you don't do that, there are crevices, sinuses that collect food debris and can be a nuisance. So ideally, a small day case procedure, obviously under general anaesthetic, about 3 weeks after the first. So this is now the tip, the suture through the tip. You can see that the flap goes all the way over to the opposite alveolus. On this right side, it'll be the pedicle of the nasal flap that's excised. On the left side, it'll be the oral flap, the left-sided flap. If you do wish to fast forward, at the end of the tape, the post-operative brief speech recording and a lateral video fluoroscopy is shown, so you can look and see the outcome at about 4 months after the operation. But it's probably worthwhile just waiting until the closure of the left-sided cheek defect is demonstrated. However, that is fairly standard. The things to avoid in closing the cheek are damage to the parotid duct again, trying to push the buccinator fat pad back into position. So here we are, trying to make sure that this pedicle is hitched up behind the alveolus to avoid a risk of the pedicle being bitten off. And the other important thing about the cheek closure is not to make it complete. You want a place where blood can escape. In fact, closing it completely at the very posterior end is often impossible, and sometimes you do need to let the gag down a little when it gets a bit tight. So the flap looks pink. Maybe the extension into the fistula side is a little more dusky. Now the posterior edge of the tip of the flap . All of this with 4.0 monocryl, could be 5.0. I know many surgeons would prefer to use Vicryl. The reason I don't like Vicryl is I don't like the way it saws through the tissues. I don't like the way I don't like the fact that it's that it's braided, and therefore causes more reaction. And also inside the mouth, it collects debris in a way that monocryl doesn't. So vicryl sutures a couple of weeks after an operation are usually covered with a lot of food debris. And however, it's obviously another option, and many surgeons prefer it. So that's the approximately midline stitch suturing the posterior end of the flap to the oral mucosa. And even if we hadn't needed that anterior extension for the fistula, we'd want the flap to be widest in the middle. That's where you want the maximum increase in length of the palate. I have seen buccinator flaps where not particularly in my own cases, but where the flap really only just about reaches past the midline. In other words, where the lengthening in the midline is not as great as you would like. And of course that means that you've got to take the flap as far forwards as possible, up to the commissure, and you've got to free the flap sufficiently to be able to reach the opposite side. Again, angling these stitches a little so that the tension is taken off the tip of the flap. Inevitably, there must be some division of lesser palatine nerves in this procedure, but that applies to many primary palate procedures where the flaps are very radically dissected, and to some extent in re-repairs. We don't really know the significance of that as far as sensation of the palate, and whether the sensation is a factor as far as function is concerned. Presumably not a major factor, otherwise the operation wouldn't work. So that flap is well, even disregarding the extension into the fistula site, at least 1.5 centimeters wide, probably more. So another stitch just to anchor that anterior edge of the flap up behind the alveolus. Okay, well now we're moving the, I decided not to put that stitch in, it was just, the flap seems to be held up. So rotating the microscope around now to just show closure of the left cheek. And here I am using Vicryl because I think it's a bit more, it's not as prickly as monocryl. Trying to pick up the buccinator muscle itself with the mucosa. And when we get back to the position of the parotid duct, being careful not to take bites that are so big that they might damage the duct. And more posteriorly, making sure the buccal fat pad, which you can see there, is not going to sort of hang into the mouth. Even if you can't close the mucosa directly over it, at least picking it up so that it doesn't. It's sort of held back by the suture. You can see the blue mark there of the parotid orifice. Now we're just going to close the defect created by the V-shaped extension there on the left, inferiorly in the patient. So that was one edge of the V. And the other edge, other corner. So this is 5/0 Vicryl. So having explained why I prefer monocryl, I'm now using the Vicryl, which I like less, but a bit kinder in the cheek, I think. It probably doesn't matter. So that's the vertical closure of for the extension, the defect created by the extension of the flap. And then the rest is basically as you would expect. As I say, at the back, picking up the buccal fat pad with the stitch, just to keep it out in the cheek and ensuring that it doesn't get bitten off by the teeth. And each suture trying to pick up a little of the buccinator muscle with the mucosa. This again is not doesn't need to be a watertight closure, as long as the buccal mucosa heals very well, and so as long as the edges are reasonably well opposed. So this one's in front of the anterior to the parotid duct, again picking up the buccinator. I'll just show a little more of the closure on this side, but then we won't include the closure on the other side, which is just a repetition. But simply show the situation at the end of the procedure. Okay, one more stitch in anterior to the duct. To Wharton's duct. To the parotid duct. And then a small bite posterior to the duct, just to make sure we don't damage the duct. Depending on how wide the back of the flap is, the proximal end of the flap is, will determine how much of this defect can be closed, but it's not a problem to leave it open posteriorly. And in fact, as I've said, I think it's important to leave it open posteriorly to make sure that to reduce the chances of a hematoma in the cheek. You can see that the gag has been let down a bit to make it easier to get the edges together, but at the same time it makes the access a little bit more difficult. So that's pretty well pushed the buccal pad of fat out of the cheek and or back into the cheek and away from the teeth. So that looks fairly well closed. Now the same on the other side, but a little easier on the other side because there isn't the inferior extension. So we'll cut that because it's repetitive. Now you're looking at the right side and we'll simply carry out a similar closure of the cheek on the right side. So we've now finished closure of the right cheek, just turning the head back to the midline. There's the flap. Still a bit of oozing. You can see the way the sucker tends to start things bleeding that weren't bleeding before, which is why I try and minimize the use of the sucker. So, a very important step, remove the throat pack without dislodging the tube. Letting down the gag and just doing a suction test here, putting a sucker through the nose. And you can see that the palate lifts up to the posterior pharyngeal wall. It doesn't have to lift very far because it's almost lying on the posterior pharyngeal wall, and actually stays up until the sucker is withdrawn from the nose. So on the scoring system for suction test, that's a suction test 3. Just one final stitch to sew that left-sided flap up behind the alveolus more effectively. So, just to repeat, the patient is on a soft diet for about 2 weeks. I cover with antibiotics, usually augmentin for 5 days, and the patient needs to be warned to be careful, to be aware of the fact that they could bite the pedicle, but here it is actually out of the way. It shouldn't happen. Just to remind you, this is this little girl's speech sample taken before operation.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Say ah.
Ah,
Ah.
ah,
Okay. Ah.
ah.
And this is her speech 4 months after the buccinator flap lengthening of the palate with re-repair and fistula closure.
1, 2, 3, 4, 5, 6, 7, 8.
And say baba,
Papa,
baba,
papa,
sa,
sasa,
si,
sisi,
pi,
pipi.
pri.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Say ah, ah. We got ah. Okay. And this is her lateral video fluoroscopy before surgery.
Pa pa pa. Ta ta ta. Ta ta ta. Ka. Ka. Prosh. Patata. Ahwa. تدريش او او اي اي او ماشا توبكي بويا درا توبكا بويا درا تاتو كاكا شابو باتا. Okay, come.
And this is the lateral video after operation.
Pa pa pa. Ta ta ta. Ta ta ta. Ka ka ka. I یک دو سه چهار پنج شش هفت هشت نه ده. یک دو واحد ثبت دي واحد
اثنين
قول واحد اثنين ثلاثة رابع
أربعة
أربعة
خمسة
خمسة اوكي سباس زين انا